and we have an exciting session of speakers who are going to discuss treatments for metastatic disease in a variety of tumours. So let's get started. I should tell you that the app is open for questions. We will have about 3 minutes for questions at the end of each talk. So please submit your questions and I will transmit them to the speakers. If you would like to come to the microphones, that's also very welcome. So first off, we have Professor Noel Clarke, who is going to present Metastatic Disease from Biology to Treatment, New Thinking.
Thank you, Joe. And it's a great pleasure to be able to start this. One of the features of all cancers is this process of metastatic spread. And if we cracked that, then we wouldn't have anything like the sort of problems that we do currently in our management. When we see a case like this, this is prostate cancer, and I'll be talking about the biology mainly in prostate, but it does apply to all cancers. A compressive lesion in the spine, multiple mets throughout the axial skeleton, and a bone scan that looks like this. And of course we know from, and this is data from the STAMPEDE study published in 2014, that when you have metastatic disease, you don't survive very long. And that's quite different from M0 prostate cancer, again from the STAMPEDE study, where the patients survive for a much longer period. So the biology of the cancers is different, and it's different according to where the cancer ends up. Now, when you think about how a cancer behaves, it starts in a primary tumor. It gets out of the primary tumor into the circulation, and then it has to get into the primary site, and that's a complex process. We all look at prostate cancer like this. Static pictures, we've got some more sophisticated staining, basal cells, luminal cells, electron microscopy. These are prostate cancer cells binding to endothelium in the bone marrow, but actually what it looks like is this. This is bone marrow endothelium, this is prostate cancer, and we took this dynamic photograph in our lab in 1997. It's a dynamic process. It's continually moving. And it's continually moving because the cells are changing. So in the dormant state, they have this nice structured epithelial configuration, and then they become mesenchymal. And when they undergo a process of mesenchymal transformation, that is associated with invasiveness, metastasis, tumor recurrence, and drug resistance, and on all of those things which are bad about cancer behavior. And the key to EMT is endothelial transmigration. If we take an endothelium, the cell goes into the circulation out of the primary, it has to bind to an endothelium, it then migrates its way through. And these are pictures taken in our lab, bone marrow endothelium, which is opening up and allowing the prostate cancer to go through. And this process of epithelial to mesenchymal transition is occurring in all cancers, and this is what makes the cancer behave in a more aggressive way. Now, this is what it looks like. So this is time-lapse video microscopy. These are prostate cancer cells here, and this is bone marrow endothelium here. Now, focus on that cell, which is currently amoeboid. It's nice and round. And then it starts to migrate through the endothelial barrier. Here it goes through the endothelial barrier, and it disappears. But if you keep looking, it emerges on the underside here as a long, slim cell, which is motile. It's undergone epithelial to mesenchymal transition, and it's done that to migrate. So why does a cell do this? Well, we know that the prostate cancer mutational landscape is transformed, as it is with renal, as it is with bladder, as it is with any cancer. So we have well-known ETS, TMPRSS2 ERG, PTEN, P53 rearrangements, and these are recapitulated in a different form, but nonetheless recapitulated in the metastatic state. What drives that along, we don't understand. There are a number of drivers. The change in mutation is one, the immunological environment is another. This is a fascinating paper which looks at the periprostatic adipocytes acting as a driver, and I'll show you some interesting time-lapse video microscopy of that in a minute. Now, once the cell gets into its secondary binding site, and in prostate, that's predominantly bone, in renal, it is in lung, it's in lymph node, it's in bone, and so on, it forms a little colony like this. So this is bone, this is bone marrow, nice and ordered, and that is a prostate cancer colony, very early colony. And these are prostate cancer epithelial cells in high magnification binding to the endothelium. And if we map that, we can see the process of endothelial transmigration. And in the lab, we did this. This is bone marrow endothelium in gray. These are the prostate cancer cells, and you can label them up with green fluorescent protein. And what we find is that the cell moves around, and then it sits on a junctional area. And then when the junctional area is taken in confocal microscopy, you can see the cell migrates down through and into its microenvironment. And this process is happening all the time. Tumors are constantly shedding cells. They go into the circulation. They bind to an endothelium, whether it's in the bone marrow, whether it's in the brain, whether it's in the liver, and then they migrate. So in prostate cancer, we know that the binding process takes place within half an hour to an hour. We published this in 2001. And we know that the migrational process is complete within 24 hours. And then it gets into the stroma. Now, the seed soil hypothesis we know all about. So the tumor microenvironment is critical. So prostate cancer, it doesn't grow in muscle. It grows in liver as a very late event and in the lung. But in the bone, it's there very quickly. And we can see this idiosyncrasy in different tumors, whether it's bladder cancer, renal, or whatever. And in the microenvironment, we have tumor cells, stroma, vessels, immune cells, and tissue-associated cells, the fibroblasts and endothelia and so on. And these are all interacting. So I'm going to focus on a specific area, and it could be any one of those areas, and this is what happens in the stroma, and particularly the bone marrow and the bone marrow adipocyte. Now, this is prostate cancer taken in higher magnification in our lab. You see the red is a fat cell, and it gets bigger, and it gets bigger, and it gets bigger. So when you look at it in detail, and this is the fat cell sliced up, prostate cancer cell sliced up, we can see it's got lipid droplets in it. And we've done migrational studies which show that the fat, the free fatty acid, arachidonic acid, is critical to this process. Now, if we look at this in a more sophisticated way, this is a publication we made from 2007. This is the bone marrow adipocyte here. Here are prostate cancer cells. We've measured that this transfer is coming directly into the prostate cancer cell. That's the fat in the prostate cancer cell. When we look at it in time lapse, 50 minutes, 3 hours, 12 hours, 43, this is what we find. Could you just play that video for me, please? So here we are, fat cell, prostate cancer cells. Look at this one. These prostate cancer cells are feeding off this adipocyte here. And as the time goes on, 3 hours, it's starting to be smashed up. The cells are undergoing EMT, and they're recruiting. It becomes a feeding frenzy around that adipocyte. And if you look at the other adipocyte, this one's now gone, this one's starting to go. The whole process is driven by the uptake of an active metabolite which induces EMT in the cell, which induces metastatic behavior, migration, colony formation, destruction of local tissue. And this is all taking place in the cell membrane, in what's called the caveolus. And this is where the signaling takes place. So in the case of arachidonic acid and caveolus signaling, we know that the prostate cancer cell migrates straight to the adipocyte, it binds to the adipocyte, and then it starts to take up cells. So this is a highly magnified prostate cancer cell from our lab. We can see, and we've measured this, that the arachidonic acid from the fat cell is taken up here. It goes straight to the mitochondria where it stimulates activity and energy transformation, and that in turn stimulates cellular migration. And if we look at that in a more sophisticated way, you can see this is a time-lapse complex experiment conducted in our labs where we fed the prostate cancer cells. We can see them transforming into a mesenchymal type. And if you look at the time scale here, 10 minutes, 30 minutes, 90 minutes, and so on, you can see the uptake and acquisition of metastatic types as soon as you feed that cell something which makes it migrate. And we know that signaling molecules like ephrin A2 and AKT are critical to this process. There's a lot to this, much more to get through than in 10 minutes, but what we know is it doesn't just depend on metabolomics, on individual fat cells. We know now that the prostate cancers can spread from the primary to the metastases. This is a paper in Nature last year, and we know that metastases will spread to metastases and form other metastases. We're trying to work this out. We've got a long way to go, but it is critical to how we think about cancers in general and how we manage them in the future. Thanks very much.
Thank you, Noel. We do have some time for questions, if you'd like to make your way to the microphone. Anyone with a question for Noel? And don't forget the app, everybody. I'm looking to see if anyone's got questions there.
Noel, can I ask a question? So look, this metastasis to metastasis spread, is the biology of that process very different from the biology of metastasis from the original tumour? And is there more variability, is there more heterogeneity in your metastasis than your primary tumour?
Well, I don't know the answer to the first question, Tom. What I can say is that metastasis is critical to cell number. So as the cell number goes up in the circulation, the statistical chances of a metastasis occurring and developing as a micrometastasis goes up, it increases. If we also take the most aggressive types, the stem cell phenotype, and we put that into our cultures, we can grow those much more readily. So, for example, if we're starting a culture, we need 10 to the 6 cells. Usually, we take a bit of prostate, put it into our culture, we need 10 to the 6 cells. If we take a stem cell phenotype, we can do it with 10. So, cell type, environment is critical. Now, what's the influence of the primary? We don't really understand. What we know in renal cancer, if we take the primary out, the patient lives longer. We're currently looking at this in prostate, where we're irradiating the prostate in STAMPEDE in metastatic disease to see if it slows down the progression. And there may be some signaling between primary and secondary. But I think once the disease load gets so high in the skeleton, the cells are being shed and migrating and re-implanting. Now, we know that there's heterogeneity amongst those cells, but we also know that the basic trunk mutations are very similar. So I think there is probably some basic mutational process which could potentially be blocked, however that's blocked, which will stop MET-to-MET transformation.
Thank you very much, Noel. Shall we move on to the next speaker then? So I'd like to welcome Axel Becks to the podium. Axel is going to talk to us about surgery for metastatic renal cancer and what do we know. Axel.
Well, thank you very much for the introduction. I also would like to thank the organizers for having me invited. It's always a task to talk about these topics and what do we know. In fact, very little, but I will show you in the next slides. I would like to start first with sketching the magnitude of the problem. These are GloboCan data, and mind you, GloboCan organization depends on countries that do have tumor registries, so the real incidence of renal cell carcinoma is probably much higher in the world. But if you add to this data from epidemiology on metachronous disease or primary metastatic disease, we can assume that about 160,000 patients develop metastatic disease annually, of which 37,000 non-clear cell renal cell carcinoma, for which we do not really have systemic treatment at the moment. The distribution of metastatic sites, and I don't think that comes as a surprise for most of you, is still the primary site is the lung. There are good reasons for that. It's probably hematogenic spread. There may be a sort of homing there, but it may as well be a lymphatic spread that goes through the thoracic duct. But for me, it was quite a surprise that second is already bone. And in fact, when we performed the SIRTIME trial, which investigates the sequence of cytoreductive nephrectomy with sunitinib, we discovered that one of the main ineligibility factors was having bone disease only, which was an exclusion factor because it's non-measurable disease. And then it went down to lymph nodes, liver, brain 8.1%, and very minor locations. Now, the rationale for surgery is actually that hasn't really changed. There is always this promise of cure. I think cure, we have to clearly state that, is only an option if you have oligometastatic disease or solitary lesions. Most likely you're to improve disease-free survival in those where you cannot remove all disease, progression-free survival, and potentially overall survival. But this is unproven by studies, as we will discuss. Another aspect may be the delay or discontinuation of targeted therapy. This may change in the future because IO has less side effects, as we have seen. But the targeted therapies do have side effects that are worth delaying if it's not really necessary. And of course, if symptomatic, you may palliate symptomatic tumors. But I do not really want to go into detail here because this is a different topic. Let's start with primary metastatic disease. I'm sure most of you have learned during their training that about 30% of these patients are primary metastatic, 1/3. There's this sort of 1/3 rule that is continuously repeated in reviews and picked up. But we see from epidemiological data from countries that do have these data that it's actually going down. Sweden was able already in 2005 to show a decline to 23%. That is down to 15% in 2010. Germany, they have some counties where they do have tumor registries, like in the Saar area where it was down to 17. Netherlands, when we did the guideline evaluation, 18% in 2011, and the SEER data in the US, 18%. I don't want to say that applies to all countries, but there is a decline in incidence. We do not know why that is. You may guess it's probably because we detect more small renal masses, but this is unproven. The other thing that we know is that in the present situation of targeted therapies, a lot of clinicians probably have decided for themselves we cannot cure patients, we prolong their lives, and with these primaries in situ, probably we achieve some good effects if you do not do surgery. So there's a general decline in the use of cytoreductive nephrectomy, especially in the US. Tony Chiari has just published in JCO the data of the National Cancer Database, and they're down to 30% cytoreductive nephrectomies. And I would also like to draw your attention to your own data from the Bowes nephrectomy registry in 2012, where it was shown that only 4.6% of all nephrectomies performed in this year were cytoreductive. And if you break that down to the number of surgeons and centers involved, then, well, it will not be evenly distributed, but it's not a kind of surgery that is performed very often. There are retrospective data, and that was for a review we wrote recently. We looked at publications that compared surgery to no surgery in the era of targeted therapy. There seems to be a huge survival difference, but mind you, this is retrospective, this is heavily biased, and there is always a reason why surgery was not performed, and many of these studies just lump sum these patients together, and I don't believe these data, and I think we will be in for some surprises when the randomized trials that are ongoing will report. Carmina is still ongoing. I know from the safety analysis that there are 380 patients. I cannot disclose any data here. Certime has closed with 100 patients because of poor accrual, but after the FDA approval of a 3-arm study with 50 patients per arm for lenvatinib and everolimus, I have good hope that we will get some results from Certime as well. Now, in the meantime, what should we do? I think there's little doubt in resectable low-volume metastatic disease. This is in the guidelines. If you can resect all disease, you should do that. Again, here, the reason is potentially curative. It may potentially prolong progression-free survival. But I think another very important aspect, as already mentioned, is that it may substantially delay targeted therapy. These are data from our own center where we looked at 28 patients. All these patients were discussed at multidisciplinary tumor boards. They had, you can sum it up, too little for systemic treatment, but too much for resection. And so we decided to do cytoreductive nephrectomy and just observe these patients. Some of these patients were actually observed beyond progression of some individual lesions. And the median time to targeted therapy in these primary metastatic patients, which are usually regarded as more aggressive than metachronic patients, was 14 months. So there's some music in there. I don't want to suggest that it was because of the cytoreductive nephrectomy, but it shows that some patients do have a very indolent disease. What we will have to do in the meantime, before these trials read out, is we will have to rely on some decision-making scores. There are scores developed by surgeons like the MD Anderson score, even nomograms, but they have not been validated. I would suggest we use these validated risk scores in the meantime, and Danny Heng has shown very nicely that if you are poor risk far down the risk factors here, then in retrospective analysis, there wasn't a statistical difference in overall survival. Again, here we will have to be careful with these data, but for the very, very poor patients, I don't think that there is room for a cytoreductive nephrectomy. Critics may say these scores have not been developed to decide about cytoreductive nephrectomy, but it comes down to clinical decision-making. Let's move on to metachronic disease. One of the major questions is always here, how often are these patients actually candidates for metastacectomy? With the EAU guideline, we are actually collecting and setting up a database. We have now included 2,000 patients to investigate whether follow-up is making sense. We broke that down into the Liebowitz risk scores. And this was part of a pilot study we performed before between the center in Amsterdam and Utrecht. As you can see here, the recurrence rate of non-metastatic disease is roughly 30%. And then 28 of these 68 patients were potentially curable. That is arbitrary. It was retrospectively assessed. We just looked at the sites and we argued, yeah, well, these patients could have been resected. And these were 41% of all these recurrences detected. But in reality, only 19.1% of the detected recurrences would be resected. And you will have to live with this clinical reality that some patients have poor condition, or they have an expected rapid progression rate, or there are technical issues. So by very conservative measures, we believe that about 19% of patients who develop metastatic disease are probably candidates for metastasectomy or some form of local treatment. If you do that then, and this is again an overview of multiple retrospective studies, then the 5-year survival time is in the range of 50%, with the exception of brain and synchronous lymph node metastasis. This has been repeated again recently by another group, but Pantuk was the first to publish that. Interestingly, there are two cancers that do have very long-term survival. That is pancreas. There seems to be some other form of biology, and the lung as well, depending on the series that are published. And the same goes for multiple metastases and sites. This is again one of these lump sum publications from the United States, where they looked at patients that had more sites completely resected. Most of these sites were actually lung, but the cancer-specific survival was impressive at 5 years, versus only 19%, if not completely resected. And very interestingly, and we all know these cases, they also exist with multiple metastasis resection over time. Now, this is a series already from 1998, where they did resection, or even third resections. And when you add that up in these individual patients that were observed, the 5-year overall survival was 43%. We did a systematic review with the EAU guideline committee to just see whether we could come up with comparators. It was a titanic task, just to sum it up. It was performed by PRISMA guidelines. More than 2,200 abstracts were identified, and eventually only 16 could be identified that had comparators in them between metastasectomy versus incomplete or no metastasectomy. And these are the results. This is a force plot of hazard ratios, but mind you, those who use Review Manager will realize this is not a diamond, so all these studies are retrospective, and that means, although it shows a favor for metastasectomy, if you look at the risk of bias table, it's almost completely red. This is another systematic review we did on sequencing of targeted therapies, where we had a lot of RCTs, so just to show you the difference. And that's always something you have to bear in mind. A lot of these data are biased. And that is the major flaw. All these series have probably described metastasectomies from patient populations with a benign tumor biology, and then compared them to their own data sets of patients who probably never had been candidates for surgery. Add to this a certain, well, we could call this an oncological uncertainty principle. You know that the Copenhagen interpretation of quantum mechanics plays with this position and momentum. So we could say we know the location of metastasis, but the time you diagnose is you very rarely know the development of the disease. And this all adds to the fact that we do not really know what the true impact of metastasectomy is on survival. Some would argue it is most importantly that you have relatively benign tumor biology. Metastasectomy adds to it. Others say metastasectomy is very important, but the same may be true here, and it has never been proven in randomized studies that relatively benign tumor biology is all, and it eclipses whatever you do with these lesions. What we do know is, and these are again retrospective data from France, there was another series from Germany a couple of years earlier, that if patients respond completely either with TKA together or some form of local treatment, admittedly a very small series here, but most of these patients had surgery or radiofrequency ablation or radiotherapy, but half of these patients were still in complete remission without targeted therapy after a period of 1 year. And this gives room, and it is already practiced, and I think there's a trial ongoing at the Cleveland Clinic where they stop targeted therapy when they see partial responses or responses. So there is some reason to think about that here. Selection is key. I don't want to go through all these details for those interested. Patient factors, extent of disease, the cause of the disease, the time to metastasis, the surgery, whether it was complete, the biology plays a role. And you do have even nomograms, which are site-specific, like the Munich score or the RTOG, RPA classification for brain metastasis. Most of them are not validated. But if you embark on the mission of doing treatment of metastatic disease, you will have to know about all these factors that influence it. You may want to use one of these metastacectomy scores that have been published recently, but again, this is not validated. And again, it plays with the factors, with T-stage, the grading, disease-free interval, whether these metastases are non-pulmonary, and whether these are multiple sites. I would like to finish just briefly because there are always these questions, should we pre-treat patients, can we downsize them? These are data from our own clinic where all these patients were included in multidisciplinary tumor board decisions, where we felt the extent of the disease was a bit too much to approach surgery up front. I know it's a sort of gut feeling. It's difficult to describe why. And here you can see the baseline size of these tumors, the diameter, and then the downsizing. The ones in blue were resected, but there had been others where, due to the location that was retroperitoneal space, even though we had a downsizing by 12%, it was not attempted, and in others the resection was incomplete. What it does not tell you is whether it was necessary to do that. And with this, I would like to conclude that complete resection may offer cure for some patients, probably a prolonged overall survival if they are selected appropriately. There may be room to stop therapy in those in whom we can completely resect the disease, who had been under therapy before, but there is no or very little data about targeted therapy in conjunction with metastasectomy. Thank you for your attention. I'm taking some questions.
So this is now open for questions. While people are thinking about that, Axel, may I ask you a question? How will we refine further selection for who to do resection of metastasis and who we can't benefit? Is there, like other tumour types, biomarkers and this sort of thing coming forward that may help us in this?
Well, unfortunately, at the moment, there is no biomarker, and I haven't shown the data. Together with Tom, we published sort of meta-analysis of 2 phase 2 trials, and you did the Panther trial. I think one way forward in the meantime could be to just pre-treat patients with the primary tumor in situ, and then resect it when it becomes obvious how the patient is faring. So you use the response to systemic therapy as a decision-making tool. There's the clinic at the MD Anderson who do that, but for metastasectomy, we do not really have these data. I think you wouldn't want to expose a patient in whom you can achieve a complete resection to targeted therapy without any reason. So I think that's difficult.
Any other questions for Axel Beggs, please?
Axel, could I ask you a question? Congratulations on doing a study looking at the natural history of metastatic disease off TKI therapy. That's a brave thing to do, and we need more of it. How did you select the patients for observation rather than intervention?
You mean on...
This is on the delayed TKI observation, clinical observation that you've done.
Oh, these ones. Well, very often, we all know these CT scans. You know, you have patients who have 6 or 7 lung nodules. One of them is above 1 centimeter, but then the radiologist tells you, I count actually 8 or 9 in both lungs, maybe submillimetric or 6, 7 millimeters in size. Then the thoracic surgeons are not really wanting to treat these pulmonary mets. And there's discussion about whether all these indeterminate lesions are actually pulmonary lesions. But, well, these are, for example, the patients where we decide to do a cytoreductive nephrectomy and then observe them. I cannot really confirm that there may be patients among them who do not even have metastatic disease. That's another story. But for clinical decision-making, I think if you do have 2 or 3 peripheral lesions that could be completely resected, I wouldn't delay therapy. I would try to resect it. If you're in doubt about the speed of development, for example, if you resect the tumor, the primary first and it's a Furman grade 4 and it's sarcomatoid, then I would suggest to just wait for the next CT scan before you do something in the thorax. So there are a lot of clinical parameters that come into being.
Can I ask you another question about, because this surgery can be quite challenging, can't it? It's often in a circumstance where somebody's had a go and taken the kidney out and left something behind, or something else pops up. Who should do it, and how should they be assessed? Because in some areas, they're sent in for central review and an opinion, and in other areas, they're not. And we've certainly had patients who've referred themselves to us for surgery, having been told they were completely inoperable, and then we've operated on them. How should this be rationalized?
We looked into this, and there are hardly ever criteria that predict inoperability as such. I think if you have encasement of the large retroperitoneal vessels, that doesn't mean it's impossible. Even at our center, we had a patient who went to Nijmegen, was resected there, and then started to send evil letters about that. We didn't attempt it. But I think it all comes down to how aggressive you are in this situation. There are clinics in the US where they take out the retroperitoneal cava and do caval vein replacement, but mind you, this is not testicular cancer. So I think that the morbidity of the surgery has to be considered with this as well. But to answer your question, if the superior mesenteric artery is involved, the trunk and the major retroperitoneal vessels, or if the spread is multiple within the abdomen, I think these are inoperable cases. But if they're locally resectable, then we attempt that. Another sign where we believe you will have to be careful is if you do have infiltration of the psoas muscles, then there's a great likelihood that it will be R1 resected or R2. So you leave macroscopic disease behind, and there are good data, retrospective data from the MD Anderson that showed that if you do leave macroscopic disease behind, you may as well not even attempt it. So these are decision-making tools.
Thank you very much.
Thank you. Thank you.
While we're just waiting for our next speaker to go up to the podium, Noel, I have a question for you from the app. Is there a defense mechanism in bones to avoid implantation? In other words, do each of us have a different propensity for our bones accepting metastasis, I think is what they're getting at.
Well, it's a very smart question, and the answer is almost certainly yes, and there are multiple levels to this. So if you look at the, one factor we know is the adipocyte is critical to it, and the uptake of an early survival of the cell. So if you take bone marrow from different patients on different diets, then the adipocyte count goes up. So the statistical chance of a migrating cancer cell hitting a cell which it will coact with is increased. So your statistical chances of developing a critical cellular mass are up. The second thing, and we're only just beginning to scratch the surface of this, and Tom's going to talk a little more about it, is the immunological surveillance processes. We're just about to publish from the STAMPEDE study the results of the combination of celecoxib and zoledronic acid, which have improved survival in patients with bone metastases only by about a year. So that's 8 months of celecoxib and nearly 20 months of zoledronic acid, a year's survival. It's as good as docetaxel. So the question really is why? And that almost certainly is the effect, or one potential is the effect on macrophage function in the bone marrow, where we know that bone marrow, prostate cancer metastases in bone marrow have got very high interleukin-6 levels. We know that macrophage function is critical to that. We know that celecoxib, through its prostaglandin inhibition of IL-6 production, is critical. So almost certainly the immune cellular interactions are having a key role in which cells survive once they get into the bone marrow and how they propagate. And if we can understand that a bit better, we can target it.
Very good. We're going to hear a bit more about the immune system, but I'm now delighted to welcome Dr. Nicola van As to the podium, and he's going to tell us about targeted radiotherapy for oligometastatic prostate cancer. Nick, thank you.
Thanks. I'm delighted to be here. I'm really quite used to presenting to audiences which are 90% oncologists and a smattering of urologists in the audience, but I suspect today I'm completely outnumbered. I think we've probably just heard a little gem from Noel there. I didn't know that STAMPEDE data. I'm not sure that's in the public domain, but that's a fascinating result from the STAMPEDE study. So relevant conflicts of interest, all oncologists are used to declaring this sort of stuff, so I have had speaker fees and research grants from Accuray, who make the CyberKnife, which is the machine we use to treat patients. So what are we talking about when we talk about oligometastatic disease? Well, there are a number of definitions of this condition. Some people call it one site of disease, others 1 to 3, some up to 5. I've even seen publications of beyond 6 lesions and called oligometastatic. But for the purposes of our own work, we chose to define it as 1 to 3 metastatic sites. And it's essentially an evolving paradigm. And I think there's 3 terms which I'm going to be using during this talk which are worth defining. The first is synchronous oligometastatic disease. So this is where a patient presents de novo with an untreated primary and at the time of diagnosis has metastatic disease of 1 to 3 sites. So synchronous oligometastatic disease. And then the disease of which we've treated most patients and we've had most experience is oligorecurrent or metachronous oligometastatic disease. So these are patients who've had treatment with either surgery or radiotherapy as their primary treatment, and they've relapsed at a later time point with oligometastatic disease. And the third, and not truly oligometastatic, but an evolving area and probably currently more relevant in renal and lung cancer, but potentially very relevant in prostate cancer, is a concept of oligoprogressive disease. And this is where a patient has often quite widespread metastatic disease and is on systemic therapy, and the systemic therapy is controlling the disease, but you get progression at 1 or possibly 2 sites. So why have we not been interested in this disease state before? Well, possibly because our surgical techniques and our radiotherapy techniques meant that the morbidity associated with attempting to treat metastatic disease may have just been considered too high. Specifically in terms of radiotherapy, to get a radical dose with the way we used to deliver radiation, you'd have to be treating patients for 6 or 7 weeks. And that didn't appear to be a justifiable thing to do in someone who you were not going to cure. But what's changed? Well, as I said, the historical use of radiotherapy in metastatic disease has been essentially for this sort of situation with spinal cord compression and for patients who've got bone pain. And really, radiotherapy has been thought of as a fairly blunt instrument, especially by my medical oncology colleagues like Tom on the panel there. But radiotherapy has evolved. We now have fairly space-age technologies like the CyberKnife. This is a machine that we use. It's not by any means the only way you can deliver complex radiotherapy. But the LINAC, the radiotherapy generator, essentially is much smaller. It's in the head of the machine, and it's mounted on a robot just the same as robots in a car plant. On the ceiling, we have KV imaging detectors. These are just X-ray machines for diagnostic X-rays with a detector on the floor. And this is a light-detecting source. So for patients who have tumors in the lung, we put a tight-fitting vest on with light-emitting sources, and the machine models the patient's breathing. So it gets a model of the breathing. That data is fed back to the robot. The KV images take a picture of where your target is, either with fiducial markers, or you can visualize the tumor in real time. And then the robot will fire its X-rays. So it only treats when the tumor's in its path, even if the patient's breathing, so that the robot will move in synchrony with the patient's breathing. And this is one of an array of new radiation technologies. I'm not going to go through all of these. This is an ExactTrack, a TrueBeam, Calypso, tomotherapy. All of these have been developed in the last 10 years, along with a massive development in computer power that means our planning software and the way we can calculate our algorithms has changed dramatically, and it's allowed us to deliver much more complex treatments. So we can deliver far more complex shapes. So the red is where we want a lot of radiation dose, and as it gets down to blue, the dose cools off dramatically, and you can see we can do complex shapes, avoiding the areas we don't want to treat. So radiation technology has changed a lot in the last 10 years. So our experience to date. So this was presented by my research fellow at ESTRO recently, and we just looked at our first 45 oligometastatic prostate cancer patients. So we've been doing this since about 2011, and we've probably treated about 150 oligomets patients for all tumor types, but this is just our prostate cohort. So it's our first 45 patients. We wanted a bit of follow-up, so we've probably treated about 70 or 80 prostates now. And you can see their primary treatments. They had either surgery, radiotherapy and hormones, radiotherapy, surgery and adjuvant radiotherapy, or salvage radiotherapy, surgery, radiotherapy and hormones, a small number with brachy, and only one patient had surgery on its own. Most patients had a single site of metastatic disease. Some patients had 2 sites, and we treated a total of 60 lesions. predominantly lymph node metastases, bone, and there were 2 visceral metastases, 1 liver, 1 lung, both biopsy confirmed, prostate cancer. The median PSA was 5.3, and the median PSAW time was 4.5 months. So at 32 months median follow-up, 87% overall survival with 90% local control. 1 to 2 year progression-free survival, respectively, of 65 and 36%, respectively, with a median PSS of 22 months. Now, I know this is extremely small numbers, and this is a good prognostic, generally, cohort of patients. But if you just put monoclonal antibody at the end of this result, this would probably be on CNN, and I'd be cashing in my shares, making millions. But because it's radiation, it's really not that interesting. Very importantly, there were no grade 3 or 4 toxicities, very low rates of even grade 1 and 2 toxicities, and no significant late toxicities reported. And I think this is absolutely key. If this treatment was causing harm, then we shouldn't be considering it. But we can do this treatment without causing significant side effects. Biochemical control, for what it's worth, in the 45 patients, 70% at 6 months and 40% at 12 months, with a median of 8 months. So the concept really is that we are eliminating macroscopic disease, possibly eliminating aggressive clones, possibly in the castrate-resistant setting, eliminating resistant clones. But really, as Noel highlighted earlier, there's now really good, robust data that you get metastasis to metastasis spread. And there's a sort of cell count phenomenon. So the bigger that tumor is, the more likely it is to metastasize. So simply, the concept is, if you can see visible macroscopic disease and you can ablate it, potentially you can prevent the next metastasis occurring. So I'm not expecting that we are going to cure patients with this treatment. We may cure some, but that isn't really the aim. The aim is to delay progression, potentially delay the next line of systemic therapy, or maybe in some cases even avoid systemic therapy. So how do our results compare to to others? Well, this was a collaboration with European colleagues who we continue to collaborate with, and I hope following Brexit we will not be kicked out of the club. But we put seven centers together, treatment naive in the metastatic setting. They all had to have 1 to 3 sites of metastatic disease, and all these patients were staged with a choline PET scan. There were 113 patients with 163 metastases. Some of the patients had a short course of hormonal therapy, which we've started to do now as well, thinking that we know how effective hormones and radiation are together when treated in the primary setting, but we think it makes sense to use a short course of hormones when we treat the metastasis. A median follow-up of 3 years. And again, very similar results to our own, with a disease progression-free survival of 21 months. Dose matters. So this is biological effective dose. We're not giving 100 gray, but the effective dose of the hypofractionated regime is very high. And you must get a high dose in, otherwise you're likely to fail. So the median time to palliative ADT, now this isn't a very well-recognized endpoint, but I think for patients could be a very meaningful endpoint, because lifelong androgen deprivation is not a trivial treatment for men, and there are some men who really would choose to avoid it. So we looked at how long you could delay palliative ADT, and in this cohort it was 28 months. And again, very importantly, late toxicity was very, very low. So what about the literature? Well, our instructions were not to give an exhaustive literature review, but I've just one paper, this is a review article which we did a few years ago, was published in the Lancet Oncology. And we looked at what were the control rates of SBRT, so hyperfractionated radiotherapy, in all sites of oligometastatic diseases. It's not just prostate, it's all tumor types. And it looks like you can get a 20% disease-free at 2 to 3 years, very good local control rates of 80 to 90%, and again, very low toxicity. And this is across the board, a literature review. So let me show you an example. This is Mr. D. He presented in 2005, age 59. He worked as a full-time plasterer. He was an ex-professional footballer, but he played in the days where they didn't earn the kind of money that you earn now. He played for Crawley Town, but he did bring me a picture of him playing against George Best. So he was the real deal. He had a PSA of 140, a Gleason of 4+3, and 7 of 10 cores, bone scan, no mets, and a CT scan showed pelvic lymphadenopathy. Now remember, he presented in 2005. It'd be interesting if we had voting pads, but I think in 2005, many people would have considered the standard of care for this man would have been hormones alone. And unfortunately, there are still places which would give this man hormones alone. But he was actually referred to us for consideration of a clinical trial, and he was treated in an IMRT study, and he received 70 Gray to the pelvis, 60 Gray to the pelvic lymph nodes. He achieved a PSA nadir of 0.4. His LH-RH was stopped in 2008, and he remained PSA controlled until 2011. That's just an example of the radiation plan that he had. That's the nodal volume, that's the prostate, and bladder and bowel that's avoided. So he remained controlled until 2011, and then his PSA started going up quite quickly over a 6-month period between January and July. He had a CT scan which showed a solitary lymph node and a bone scan which was clear. Discussed with the surgeons, they didn't feel keen on removing this node. He had a choline PET, which showed that that was his only site of disease, and it was about 1.5 centimeters above his previous radiation volume. So it wasn't an in-field relapse. It was about 1.5 centimeters away from his previous treatment. He was referred to me for consideration of SBRT, and he in fact was the very first patient we treated, and it was filmed by BBC Horizon, slightly nerve-wracking, but it was all followed. He received 30 Gray in 3 fractions. This was his plan. Each one of those is the beam angle, so we treat from multiple beam angles. Treatment takes about 35, 40 minutes. You can see that he gets a very hot dose where the lymph node is, and a rapid dose fall-off. So this is when it gets to blue, it's at 10% of the dose. So it was important because below here he had had radiotherapy, so it was important that we didn't dump a lot of dose where his previous treatment had been. I didn't say that this man was adamant he did not want to go on hormones. He was still working as a full-time plasterer, and he really didn't want to go on hormones. That's just another depiction of what it looked like. So 1 week post-treatment, he had slight fatigue. He had no bowel toxicity and no other side effects. 3 weeks post-treatment, again, no side effects. His PSA was down to 5.9 from 21. At 12 weeks post-treatment, his PSA was 1.9. He was off hormones, never had any hormones, and he was working full-time. And he remained PSA controlled for about a year. And then, unsurprisingly, his PSA started to rise. We choline PET'd him again, and about 4 centimeters above, he had another solitary lymph node. Unfortunately, what changed then is the joy of NHS England. They came in at April 2012, and they changed the commissioning rules, and they said we weren't allowed to treat him with SBRT. So reluctantly, he went on hormones, he remains on hormones, and he is controlled at the moment. So what next? Well, I think it is important that we try and optimize how we select these patients. So we are looking at measuring circulating tumor cells and also circulating free DNA. We're also looking at imaging technologies, whole-body diffusion-weighted MRI, choline PET, and PSMA PET. We're seeing whether we can better predict who will truly benefit from these technologies and who may not. But do we have enough data already just to get on and do this routinely? I'm sure many of you will have seen this in the BMJ many years ago. There are some questions which are just so obvious that you don't actually need a randomized study, and this was the parachute paper. Interestingly, our orthopedic colleagues have just published in one of their esteemed journals a randomized trial of parachutes. They took dolls, dropped them from 25 meters, and they've reported exactly what happened. They've said that the only thing that was non-significant was the rate of pneumothorax. So they actually have demonstrated that parachutes do work in a randomized study. But I believe, despite the fact that I think that this treatment is highly valid, I think we probably do need randomized data to change practice, and this is the core study, which we are going to launch later this year. It's a CR UK-funded study in non-small cell lung, breast, and prostate cancer, and it's randomizing between the standard of care and the standard of care plus SBRT. It's very similar to a study currently running in Canada, which is Sabre Comet from David Palmer. The only major differences here is they include brain metastasis, and we do not. Sabre Comet's recruited about 100 patients already. It's doing reasonably well. And then, very importantly, STAMPEDE. Now, all of you will be familiar with STAMPEDE. STAMPEDE is a massive success achievement for UK oncology. Over 8,000 patients recruited, led by Nick James and Noel. It's been a fantastic, fantastic study, not least of the achievements was showing that docetaxel has an overwhelming survival advantage compared to what was the previous standard of care. And we've just heard a nugget of information about, which arm is it? That one, that we also have a survival advantage. So what we're looking at is when we close the radiotherapy arm, which should close next year, at looking for oligometastatic patients, whether they're randomized between standard of care, which will be hormones plus or minus chemo, to standard of care plus radical treatment of the prostate, which would either be with SBRT or surgery. A lot of debate around that, but that's the current plan. And then SBRT to the oligomets. So we're hoping that this study will be ready to open when we close it. It's going to go to CTAC for the next round of funding. Very hopeful that this will be the next arm of Stampede. So what's our current situation in the UK? Well, I mentioned that NHS England stopped us treating in 2012, and that unfortunately remained the case for 2 years. But last year we secured 15 million out of NHS England to run a commissioning through evaluation. This was their idea, not ours, of a way of doing it. It's not very scientifically valid, but at least we can treat patients. And it allows us to treat oligomets, to do pelvic re-irradiation and HCC. And we've got 17 UK centres who are open, and you need to just check whether your centre is one of them. Thank you.
Thank you, Nick. I do have one question on the app, which is kind of converting us to a bit of an MDT here. It's your plasterer, go back to 2005. His presentation today, would you still give him radiotherapy? I will give you the opportunity to answer first, Nick. Or Noel, Anthony, would you operate?
Okay, so the only thing I would do different with Mr. D now is I think I'd have a discussion about chemotherapy as well. He had heavily node-positive disease. He didn't have, he had pelvis full of nodes. So I would offer him hormones, chemotherapy, and pelvic and prostate radiotherapy.
Gentlemen, do you support that view?
I'm going to hold off on the whether I would operate on somebody just because I'm presenting in a minute. But these days we would talk to him about some chemotherapy at this point.
Yeah.
So that would be our pragmatic MDT approach in Bristol with this chap.
I think Nick, big nodes and an aggressive primary, he'd be getting ADT and radiotherapy in our institution.
One other question for me. What are the urological tumour types might this be applicable to? I wondered about testis. I'm a bladder cancer specialist myself. That might be a bit more tricky with imaging. What do you think?
So we've done quite a few bladder patients, and I think they are doing extremely well, our bladder patients. Now, I can't say whether that an oligometastatic bladder will just do well anyway, because we know that there's quite a lot of heterogeneity in the way metastatic TCC behaves, from a disease which can be rapidly progressive to a disease which can be quite indolent. But we've got probably about 10 TCC patients, and they've done extremely well. Testes, we've done very, very few, mainly because the other treatment modalities are so effective and well established. So the only testes we've done have been patients who've failed in the retroperitoneum, having had a retroperitoneal resection, and a very experienced retroperitoneal surgeon has said, I'm not going back. We've done one of those recently. And I think we've done one testes patient, but to be honest, more in a palliative setting rather than a truly curative setting.
Nick, congratulations on doing this pioneering work, and it really is very valuable that you're doing it. Institutions like the Marsden and the Christie, well-funded, big cancer centres, UCL of course, CyberKnife machines are affordable. But you don't need to do CyberKnife.
No,
it is usable with IMRT, isn't it?
You certainly don't need CyberKnife. I showed you those other machine platforms. Obviously, we didn't have enough time to talk about. No, you don't need CyberKnife. We use CyberKnife because that's the machine we have. And there are some cases where it may have some slight advantages, but that really gets down to minutiae. You can do this on any modern radiotherapy machine if you've got the will and the physics capability and you develop the expertise. You have to do it with rigorous quality assurance. Those 17 centres that are open in the UK, all of them have to go through a very rigorous QA process which is run through our clinical trials QA process. The reason being is we're giving very big doses, and if you put the big doses in the wrong place, then the consequences are serious. So you have to do this carefully. I mean, I'm not saying anyone should just attempt it without, but no, you definitely don't need a CyberKnife. You can do it on standard radiotherapy machines.
We've got it in Middlesbrough now.
Well, they're coming, aren't they? And they get cheaper. The new machines arrive, they're very expensive, and then they become standard.
And then you talk about protons.
Yeah, so then we're on to the PET scan issue and the question of what we do about this. I mean, as a surgical audience, we're increasingly being shown images of PET scanning, whether it's choline PET, whether it's FDG PET, whether it's PSMA PET in prostate cancer. And what we know is that it will pick up disease that we wouldn't previously have picked up. And secondly, we also know that different scans will show different disease sites. So how do we overcome this? Because the goalposts are shifting, aren't they, as to what is oligometastatic disease?
I think that's very true. I'm going to answer it in a way that we had in the STAMPEDE discussion, because I don't think it really matters in STAMPEDE. So for the synchronous METs, what we've said in STAMPEDE is that the patient should have whatever imaging is standard in their center. So some centers will do a bone scan and CT, and they will pick up X number of patients with metastatic disease. We would probably be there by then doing PSMA PET, and we will pick up more, but we'll also exclude some because we will say they've got 10 metastases, not 3. In a study the size of STAMPEDE, I don't really think that matters. This is my view, is that it's not about trying to cure the patients. So if you have we'll have an enriched population, which will have kind of true metastatic disease, and then we'll have the patients who just had the METs that were big enough to see. But I think the concept holds, because if you ablate the largest sites of visible disease, we may still do what we're trying to do, which is delay progression and avoid the next line of systemic therapy. So I think for STAMPEDE, it's probably okay whatever imaging we do in the study. In terms of truly defining who has oligomets, whether that's important or not, I think it's quite academically interesting, because we can do better biology studies. Which is the best scan modality? To be proven. I suspect PSMA PET's going to outperform choline, but it'll be better at lymph nodes. Bone, probably it'll turn out to be diffusion-weighted MRI that's the best.
Thanks very much, Nick. I think we're going to move on and hear the surgical counter to the discussion.
Not counter, it's the same concept.
You don't know yet. Okay, so I'd like to welcome Mr. Anthony Kaparis from Bristol, who's going to tell us about surgery for oligometastatic prostate cancer. Hyporeality, Anthony.
I'll tell you in a second. Thanks very much, Joyce. Real honour to be asked to join such a distinguished panel. If you just bear with me for a second. The talk is all about timing. Noel's actually threatened me with a taser gun if I go over 12 minutes. They're just routing it all through. Oh dear. It's on here.
I've got questions coming through on the app. Please continue to send them along. I'll try and fit some in towards the end.
That's a shame.
Okay, I've got a question here that I think might apply to Nick and Noel. Has the role of nanoparticles been explored in the management of oligometastatic disease? Imaging or therapy, gentlemen? Nanoparticles?
Well, if I can just, while Nick catches his breath, we've used, or there is evidence for iron oxide particles, which look very promising as a lymph node analyzer. In other words, detecting metastatically affected lymph nodes. But unfortunately, this has failed its registration, and it's not going any further forward as far as I can see. And it's quite some years since that first publication was produced. It depends on the nanoparticle, I guess. There are a number of strategies which are being tried, some of which involve modulation of systems with injections of particles with delivery of energy, but I'm not aware of anything that is, as a diagnostic, which has shown promise beyond nanoparticles.
We'll watch that space. How are we going, Anthony?
Yeah,
are we ready to go?
It's
Fantastic.
So I thought I'd start off with a quote. Dr. Ian Malcolm said that just because you can do something doesn't necessarily mean that you should do it. What I've done with this topic is distilled everything down into 2 surgical scenarios that we come across quite frequently. Here's the first one. So we've got a chap with a PSA of 34, bilateral Gleason 4+4, and on his staging scans, we find that he's got a solitary pelvic met in his bony pelvis. So this is from a couple of years ago, and he had primary hormone therapy and had a good response, but then subsequently developed a right hydronephrosis, which required a stent, and in the future, he might have discussions about a variety of other treatments, but that's a discussion for a different day. The question for us today is, should we have done anything differently? Essentially, should he have had a radical prostatectomy? Now, what I'll do for each of the cases is go through some of the basic science, go through some of the clinical data and see whether we can provide this. So when we come to essentially a cytoreductive approach in prostate cancer, it's not something that's traditionally thought of a good idea because treatment of the primary might not affect the bigger picture, but the aims, what we're trying to do is improve survival, obtain good local control. Could we improve response to systemic treatment? Could we delay it? Could we even delay castrate-resistant prostate cancer? And could we interfere with some of these metastatic primary site interactions we've been hearing about? So, the seed and soil theory, Paget, 1889, he was talking about breast cancers in the Lancet. If we remove the primary, we might remove some of these promoting factors at the microenvironment at the metastatic sites. Could we remove some of the source of metastatic cells and maybe even decrease our circulating tumor cells? We know that from De Bono's original work here, if you've got lots of CTCs, you're going to have a poor prognosis. So there's lots of basic science out there. The top study looked at tissue from patients who'd had a year's worth of hormones along with 3 cycles of chemotherapy. And what they found was that there were significant molecular networks that remain active despite a year's worth of pretty serious treatment. You've got this Nature article here from the Hopkins Rapid Autopsy Program, and what they were trying to work out is where do all of these metastatic sites come from? And they found that there was a single genetically distinct clone from in the primary, which was the source of all the metastatic sites. And then at the bottom, we've got Hafner's study, which looked at a single 47-year-old man over a 17-year period. And again, they found a single lethal clone from the primary that was ultimately the cause of his death. So if we take the primary out, we might interfere with these processes. Clinical data. So the top study, it's a Mayo study. It's quite old now, but they looked at prostatectomy and orchidectomy versus orchidectomy alone. You can see quite a big improvement in the 10-year overall survival. The 2 middle studies are basically similar in that they're working out whether you should complete a radical prostatectomy with positive lymph nodes, and they both found an improvement in cancer-specific survival and overall survival. And then you've got Thompson's study at the bottom there, which is a retrospective analysis of the SWOG trial, which was looking at orchidectomy and flutamide. And the patients that had a radical prostatectomy before treatment had a 51% risk reduction in their death rate. What about more recent papers? Well, we've had a good SEER-based study from the University of California. This is one in the European Journal from last year. We've got 8,000 patients, M1A to M1C disease. Significant improvement in overall survival if you have either a radical prostatectomy or a radiotherapy technique to the primary. It was irrespective of the M stage, and they tried to deal with the fact that basically you only ever operate on people who are fit or irradiate people who are fit. So they took out everybody who died within 12 months of diagnosis, and they found the same result. Finally, this is a paper from Cologne from last year's ESU meeting. It's a retrospective case-controlled study. They looked at 2 groups, 6 months of hormones and a radical prostatectomy versus initial hormones. There was an improvement in cancer-specific survival. There was a delay in the development of castrate-resistant prostate cancer. There was a delay in the introduction of systemic treatment. Interestingly, no difference in functional outcome in terms of continence if you compare it to a group of low-risk patients. And in the hormone group, 29% of patients went on to either need a long-term catheter or a ureteric stent for upper tract obstruction. So, should we do a radical prostatectomy in these patients? Maybe in the right setting. We're certainly going to interfere with some of these basic science interactions we're hearing about. It's the ultimate local control. The Cologne study mentioned 29%, but actually in many of the studies, we're seeing local symptoms in upwards of 40% of patients. we might improve survival and we might delay treatment or even the development of castrate-resistant prostate cancer. So we can do it, and I think we should do it in certain patients. I think a posterior approach, when you're doing it, will deal with the concerns about the rectum. A lymphadenectomy, at the very least, will provide you with valuable staging information. It might even have some oncological benefits. People always talk about margins and negative and positive margins. If you extend your dissection out into the lateral fat pad, and then when you come to control your pedicles, if you join the two up, you can actually achieve specimen confined rates of up to 70%. And then do a good job around the apex and with your anastomosis, and you can have very, very good functional outcomes. So that's the first half of the talk. Second case, again, 18 months ago, this chap, 64-year-old, bilateral Gleason 3+4. He had some patchy change in his peripheral zone. He had a radical prostatectomy, and he ended up with a Gleason 4+3. T3A, margins were negative, but I didn't take any lymph nodes because I thought he was an intermediate risk patient, and his postoperative PSA was 0.4. So, staging MRI and CT, unhelpful. He had a choline PET scan, and you can see it up there on the slide. He's got a solitary right obturator lymph node. So we had a long chat with oncology colleagues, with us. We did a salvage lymph node dissection. He had nothing in his right obturator lymph nodes, but he had a positive left obturator lymph node and a positive common iliac node on the same side. Post-op PSA was 0.67. So what are we trying to do with a salvage lymph node dissection? Well, partly we're translating the data from high-risk prostate cancer patients and an extended lymph node dissection where there's an approximately 20% improvement in the biochemical recurrence rates. Could we have a beneficial oncological outcome? We might even be able to cure these patients, but we'll see. Could we delay systemic treatment? Could we delay progression to castrate-resistant cancer? So again, a little bit of basic science. These guys were looking at microRNA signatures, and they were looking at the hypothesis between oligometastatic, polymetastatic disease. Basically, they showed that there was a continual interaction between the metastatic sites and the primary, and it wasn't a one-way street with the primary driving the process. The metastatic sites can also reseed the primary, which can lead to progression. We've already seen this paper. Gundam was using whole genome sequencing to look at the subclonal architecture. And again, we've seen this metastatic site to metastatic site process occurring. If we take these sites out with a lymph node dissection, could we interfere with this? So what about clinical data? So we've got one of the largest series to date here, salvage lymph node dissection guided by a choline PET. 57% of the patients had a response. However, 32% of them received adjuvant hormone therapy as directed by the physician who was looking after them. Of the 70% or so who didn't have hormones, 86 progressed. And you can see an update to this series by Sawadi from last year. So your biochemical recurrence-free survival at 5 years is 19%. And that's not overall, that's in those initial responders. There are a variety of publications. I've picked two here. So again, Sawadi at the top, data from 5 tertiary centres. You've got a really good review article from last year from the European Journal. If you do a salvage lymph node dissection in these patients, about 50% of them will respond, but it's only durable in 20%. And it's all about patient selection. So if your PSA is less than 4, if your Gleason is 7 or less, and you've only got pelvic lymph node involvement, then you're far more likely to have a success. But it'd be quite interesting to see what would happen if you did absolutely nothing with those patients. So where are we going wrong? Well, let's just remind ourselves how prostate cancer spreads. So the paper at the top is relatively old now, but you can see these are the primary landing sites for prostate cancer, and you can see the huge anatomical variation. And at the bottom, we've got a figure from the Rigatti paper that I mentioned before, showing the metastatic sites themselves. And again, huge variation throughout the pelvis and throughout the retroperitoneum. We're not dealing with TCC. It's not a stepwise progression. What's the other issue? We mentioned it before, imaging. It's all about imaging. So unfortunately, CT, bone scan, and MRI are not reliable. I'm mentioning multiparametric MRI for completeness. It might be helpful for local recurrence with low PSAs, but you need to wait 3 months after you've done an operation before you use it. Whole body MRI seems to outperform bone scan, but it's equivalent for CT when we're talking about lymph node mets. PETs, FDG, no use. Choline, no use with low PSAs. You're more likely to have a positive PET scan if you've got a rapidly progressing PSA. Huge number of meta-analyses on choline PET scans. Initially, very, very good sensitivities and specificities, but they were comparing the choline PET to traditional radiological techniques. If you combine it with some pathological confirmation, actually your detection rates start plummeting. The last meta-analysis that I read showed a detection rate of 36%. So from a surgical perspective, at a lesion-based level, choline PET performs very poorly. What about PSMA? Now, PSMA is a transmembrane protein. It moves from, it's basically overexpressed with neoplastic transformation and high Gleason scores and castrate-resistant prostate cancers. Here are a couple of initial assessments. It certainly outperforms CT and choline PET. The guys in this is a Heidelberg paper, they combined their observations with pathological confirmation, actually came up with a group of sensitivities and specificities which were quite positive. So what about clinical data? This is, I've used abstracts from the EAU. This one in particular was very, very honest. It comes from Melbourne and Declan Murphy. So they did a salvage lymph node dissection on 14 patients, had a decent lymph node yield. The average number of positive lymph nodes was 3. Your average pre-op PSA was 2.1. Average post-op PSA was 1.39. The number of patients who actually responded was 1 out of the 14. But we're surgeons, we don't care about biochemical recurrence. We want overall survival and cancer-specific survival. That's what's important. So Freiberg and the Martini Clinic also presented this paper. And they found a dramatic overall survival advantage, 88% versus 46%. But then, again, we come to the elephant in the room, and 62% of the patients who had a salvage lymph node dissection also had radiotherapy to the retroperitoneum. 75% of them were on hormones. So, conclusions. Salvage lymph node dissection, unproven. It's all about the imaging. The problem with the literature is that it's littered with multiple adjuvant and salvage therapies, so it's impossible to work out which is best, what combination, and what sequence. My gut feeling is that we've got a systemic disease in these patients, and we should be working out when to institute systemic therapy and working out whether we can delay that therapy. What do we do about it? We've heard Stampede again and again and again, and I think as a group of surgeons we need to learn from our oncology colleagues. I think there's an enormous amount of work that's been done by PS, Vincent, John, and Newcastle. We need to combine the patients who we can really make a difference in. I think we bring together the high-risk clinically localized prostate cancer patients, the oligometastatic patients, and those recurrent patients after radical surgery because they form a continuum. We need to come up with a study with well-defined and meaningful endpoints, so overall survival, cancer-specific survival. It's all about the imaging. We should be able to work out what the best imaging technique is. And then we have well-defined indications for adjuvant and salvage multimodal therapies. Finally, lymph node dissection in the primary setting is relatively straightforward. You've got good anatomy, minimal morbidity, no big deal. Salvage lymph node dissection after radiotherapy or even surgery, it's a bit more tricky. Your planes are not there. You're more likely to cause damage to other structures. Any questions?
Thank you, Anthony. I think we'll have time for one very quick question before we move on.
Just put it down.
Okay.
So yours will come up.
In the interest of time, then, I'll introduce our next speaker. Thank you, Anthony. So, was there somebody at this microphone? No? Okay.
Oh, here we go. That works. Nice.
Great.
Thank you very much.
I'll introduce you first, if that's all right.
Yes, of course. Far away.
Professor Tom Powles needs no introduction. He's going to tell us about PD-L1 inhibitors in metastatic bladder cancer, a game changer. So
thanks for inviting me, and I'm sorry I'm so inappropriately dressed. I had a really bad first 10 minutes of the day, which I'm not going to go into detail because of time. The issue today, what I'm talking about, is actually quite important because we've got a new therapy approved in bladder cancer, systemic therapy in bladder cancer for the first time in 30 years in the United States, and that happened 2 or 3 months ago. It's a drug called atezolizumab, and a lot of people in the UK helped develop it, so I think that it's worth talking about. This is a really complex slide. Essentially, what you need to know is that on tumour cells, you have PD-L1 expression, and on T cells, you have PD-1 expression. And essentially, if you want to turn off the immune response here, you can do that by upregulating this axis here. This is effectively the brake. It's going on in all of us all the time. Naturally, it's happening between dendritic cells and T cells. That's normal. And, so when you get a cold and it begins to get better, it's not because the T cells just drift away. It's because of this process is ongoing, and that's why one recovers. However, the cancers have hijacked this as an immune protective coat. And we have PD-1 inhibitors and PD-L1 inhibitors. And for all intents and purposes, I'm oversimplifying a tiny bit, but I would assume at this stage they're identical because we have no biomarkers or no clinical data to suggest the two are different. Now, there is a lot of science that's different between the two, and we could talk about it for 3 or 4 hours, but essentially where we are at the moment is there are very few distinguishing features between these clinically, and this is going to be a very clinical talk. This essentially is a drug called atezolizumab. It's a phase 1 study, and it's in bladder cancer. And there are 2 or 3 key issues about this. This is a waterfall plot. This is the cancer's getting smaller, the cancer getting larger. And this is in cisplatin refractory disease. A lot of our patients were included in this trial. 2 key factors. Number 1 is if you overexpress the biomarker, you're more likely to respond to therapy. So the biomarker appears to be important. So if your tumour overexpresses the biomarker, it kind of works. And then the second thing about this, which I think is important, is historical response rates for drugs like vinflunine in this setting are about 10%. And you can see here those response rates are going up in the region of 30 or 40%. 2 other key things about these drugs. Number 1 is they're exceptionally well tolerated in the vast majority of patients. So the majority of patients who we treat don't know they're having it. Don't get me wrong, there's some severe side effects too. I've got a patient in ITU right now. But the majority of patients get away with this therapy, number 1. And number 2, and this is the key to this at this stage, is those individuals who respond have long-term durable responses. So of the patients who I've treated who have responded, which is 30 or 40 now, those patients seem to go into a long-term durable remission, whereas chemotherapy, you respond and then relapse again. So number 1 is it works, number 2, it's well tolerated, but number 3, if it works really well. And that's why the FDA has given rapid accelerated approval of this drug. This is a phase 2 study which is a larger study, looking at exactly the same study as I just showed you. You might say, why do it twice? Well, we have to confirm the original findings. So this is a group of patients who have failed cisplatin chemotherapy. It's a classic group of patients, 66 years old, average. You can see here the majority have had multiple previous regimens, lots of liver metastasis. This is bladder cancer that's come back after cisplatin-based therapy. A bit more detail about the biomarker. So only 1/3 of patients overexpress the biomarker. You might remember that if you overexpress the biomarker, you do better than if you didn't overexpress the biomarker. So this is important. So we may be able to select patients who benefit from therapy. And you can see from here, this is the response rate. And the response rate actually is relatively modest in this population. So response rate in the positive population of about 30%, about 15% in all comers. It's still higher than we see with historical chemotherapy. But the provocative thing about this slide is, are we treating these patients at the right time? Should we move the treatment forward into the first-line setting? And the answer to that is, of course we should. The next key point about these drugs is they don't stop your cancer growing. The average progression-free survival is actually very short indeed at 2.1 months. So these radiological tests that we've developed for these drugs are actually somewhat inappropriate because the key to this finding, these drugs, is there are subgroups of patients who benefit, but initially, because it's not targeting the cancer cells initially, it's targeting the immune cells to then fight the cancer cells. The cancers often initially grow before they stabilize. which means we're getting an effect called pseudo-progression. So they hit progression-free survival, but they seem to continue to do well on the drug 6, 12 months down the line. So we don't know who the winners are yet with these drugs. This is an important slide because there is still a grey area about what effects these drugs are going to have on overall survival. You can see here the PD-L1 patients doing better than the negative patients. But how this compares to control arms, how this compares to historical chemotherapy, we genuinely don't know. It's my personal feeling, and we've got 2 big randomized trials, one of which was led from the UK, coming out in the next 6 months of 1,000 patients each, 2 big studies. My personal feeling is we're going to show hazard ratios in the region of 0.7, a 30% delay in, or 30% increase in survival, but also there's going to be a plateau to these curves in that there'll be groups of patients who go into a long-term durable remission that we weren't seeing before. So this is a big issue for these drugs. Here's the toxicity data, and you can see here this is all grades, but essentially these drugs are exceptionally well tolerated with the exception of reactivation of rash and other immune-type diseases, some of which, in about 5% of patients, can be very serious indeed. I've talked about a drug called atezolizumab so far. Atezolizumab, for what it's worth, is a PD-L1 inhibitor. It's the drug that has a license, and it's a drug that's in bladder cancer. It's miles ahead of the field, actually. But other drugs have been tested, like nivolumab. You can see here a very similar waterfall plot curve. And actually, if you want to go under the bonnet and look in detail at the work that other drug companies are doing, you can see data on durvalumab, which is a PD-L1 inhibitor made by AstraZeneca, pembrolizumab, evalumab. There are various different drugs being developed, all exactly the same way in the same disease process. So there's going to be intense competition. And in fact, there's a rush to develop these drugs in the first-line space. The more you look at the biomarker in detail, the less reliable it becomes. And you can see here, this is the atezolizumab data. This is the phase 1 where it looked great, and then the phase 2, maybe less good. And here's the frontline data in untreated patients, and the biomarker becomes less good again. So essentially what we're doing in the biomarker space is the drugs look like they're really active, but we actually are understanding of how they work and in whom they work from a response perspective and from a biomarker perspective is decreasing. So there's a huge amount of work still to do. All the drugs, when you compare them, actually look very safe, so they all look very similar from a safety perspective. So it may turn out to be the biomarker piece that distinguishes these drugs from one another. I've got 3 or 4 slides right at the end, and the reason why these slides are important is because this is now, for the first time, these drugs have been moved into the metastatic space in untreated patients. So this study is a cohort of 100 patients who have had untreated disease. This is their patient characteristics, a classic group of patients, untreated, metastatic, bladder cancer. And the response rates look about the same as in the second-line setting, but I said before that response and progression-free survival weren't great surrogates, and that's true. And the reason for this is there's a huge group of patients who are getting stabilization of disease. And it's very likely that with immune therapy, stabilization means the same as response to chemotherapy. And this is the last slide I'm going to show you today. And this slide is actually the overall survival slide in the first-line setting for patients. These patients had advanced disease and poor performance status or poor renal function. Their expected overall survival was only 9 months. You can see their median survival here is at 15 months. Now, if this translates to the ongoing frontline randomized trials, we're not going to have hazard ratios of 0.6, we're going to have a hazard ratios of 0.5. We might be able to double the life expectancy of these patients by giving them upfront immune therapy. So this slide here, presented about a month ago at ASCO, will change the way, or has changed, the way we look at this disease process. It's conceivable these drugs will get an upfront license in the United States in the next 6 months. And what we may be in the next 2 or 3 years is chemotherapy will be seen as a second-line palliative option, and patients will be given front-line immune therapy. That will either be single-agent immune therapy or combination immune therapy with other drugs, such as CTLA-4. This space is moving so quickly that I could show you another 20 or 30 different slides showing how it's continuing to develop. But I think what I'm going to do now is leave it with this slide. This is very provocative. This was the first slide. You may have seen this before, but this slide will change the way we treat bladder cancer. Thank you very much.
Thanks very much, Tom. Low toxicity. I know there are developments and trials for adjuvant treatment. Tell us about that. Is it going to have an important role then, do you think, for disease that we recognise as being high risk post-cystectomy?
So there are 2 adjuvant studies that are ongoing, and there's 1 non-muscle invasive study. The 2 adjuvant studies are big randomised phase 3s, both of which are open or will open in the UK. The issue around toxicity is that the nivolumab, the first drug, was associated right at the beginning of the phase 1 with quite high incidence of what was described as a pneumonitis. In fact, when you look at the detail of the incidence of pneumonitis, it's quite rare. But there is a batch of toxicity, which is transaminitis, skin toxicity, reactivation of immune-type diseases, so you can develop type 1 diabetes. In fact, you can almost develop anything. I've got a lady at the moment on ITU with TEN. Her skin is peeling off in front of our eyes, high-dose steroids. She's on ITU. About 5 to 10% of these patients run into relatively severe toxicity. 90% have almost nothing. And the key with this, and I'm spending a lot of my time running around the world trying to make these trials successful by talking about early intervention with steroids. If you give steroids quickly to low-grade symptoms, you do not affect efficacy, but you can reduce the risk of these severe toxicities occurring. So diarrhea is a classic example. Colitis occurs. If you're having diarrhea 2 or 3 times a day, if it's chemotherapy, you might say, well, that's kind of par for the course. If it's immune therapy with diarrhea 2 or 3 times a day, they need immediate intervention with steroids, because that will escalate. And as that escalates, they can develop colitis, and some patients die from that. So the key to this is early intervention and education, which is really important. Patients love these drugs because, unlike chemotherapy, the quality of life actually improves on therapy. So in the renal cancer studies, your quality of life got better on therapy. Chemotherapy, we know it drips down. But that 5 or 10% need particularly close observation. We don't know who they are at the moment.
Tom, could I ask you a question?
Yes.
It's a delivery question, really. I mean, this data looks fantastic, and it looks very promising, and the big trials we're waiting for. But let's say you get a hazard ratio of 0.7, so a 30% improvement in bladder cancer that we've never seen before. The cost, because these are really expensive drugs, aren't they?
Yeah.
How are we going to deliver it?
So in the medium and long term, there was a frontline lung cancer trial that came out a week and a half ago. There was a press release. Pembrolizumab has a survival advantage as a single agent in lung cancer. Obviously, that's going to have a massive impact on everything that we do. The drugs are extraordinarily expensive. They've been extremely expensive to develop. There are drug companies that have invested $10 billion in trying to develop these drugs. The cost of doing the trials is $100 million a go. You can see there are 5 drugs being developed in parallel in bladder cancer. So I understand the investment, and I understand the need for development, and obviously it's an important advance. The way we're going to afford these drugs is complicated, because it's not immediately apparent to me that all of these drugs are going to be approved by NICE. We saw that nivolumab and IPI was approved in melanoma, but frontline lung cancer, that's a $2 or $3 billion investment from the country. So I think it's a very important and topical issue. One thing I would say is that having the drugs developed in parallel by different companies with similar approvals would drive competition and ultimately bring costs down. And I think that might turn out to be important for us in the future. The actual process of making monoclonal antibodies, unlike tyrosine kinase inhibitors and to some extent chemotherapy, is relatively cheap. So there has been a huge investment, and there continues to be a huge investment made. But this is becoming an increasing problem. It's not just a problem in the UK anymore, it's now a global problem. The United States is looking at the cost of these drugs and bulking a little bit. So it's becoming a massive global issue, and in fact, dare I say it, NICE led this process, and I think it is important to look at the affordability of these agents.
Tom, thank you very much. I'd like to congratulate my panel on some excellent presentations and on impeccable timing, gentlemen. Thank you so much. Thank you very much.